As the scope of dialysis continues to evolve, there is a greater need to find improved methods of temporary vascular access to better patient care and treatment. Many clinicians have commented that the ideal temporary access device would provide blood flow of 400 milliliters per minute at a venous pressure of less than 250 millimeters of mercury and be able to perform consistently over the period of time without problem. These factors would allow patients to have superior dialysis treatments and have a better quality of life. While it is important to select the best temporary vascular access device, the choice of insertion site is also important. The 90s has brought increasing clinical evidence of the superiority of jugular placements over subclavian access. There are many reasons for this. Dr. Gordon Wong, nephrologist at Credit Valley Hospital in Mississauga, Canada, comments.
With greater use of temporary venous catheters for hemodialysis, it has become evident that the complication rate with insertions via the internal jugular vein is significantly lower than with the subclavian vein. Current literature indicates the rate of subclavian vein stenosis or thrombosis to be in the range of 35 to 42%. In contrast, the reported rate of jugular vein stenosis or thrombosis is on the order of 2 to 10%. Furthermore, the risk of immediate complication during the insertion procedure is also significantly lower with the internal jugular vein approach. The risk of pneumothorax is minimal compared to the subclavian vein approach, and inadvertent arterial puncture is easily managed with the application of direct pressure to achieve hemostasis. For these reasons, the internal jugular vein should be the preferred site for temporary vascular access.
Continuing to meet the needs of clinicians for a superior vascular access device, Bard Access Systems now proudly introduces the Niagara PC catheter for temporary access of the internal jugular vein. The Niagara catheter is designed with many unique features. Round lumens for high blood flow. Soft, oval, kink-resistant catheter shaft. Blunt venous tip to reduce pressure at a set blood flow rate. Stylet with tapered tip to stiffen catheter for insertion. Pre-curved design keeps the external part of the catheter comfortably oriented away from the patient's hair and ears, while positioning the extensions flat on the chest for quick and easy accessibility. Unlike many other jugular catheters, this feature allows the Niagara PC catheter to be easily dressed. There are also 2 available suture sites. One removable suture wing allows the physician to secure the catheter at the exit site. The optional rotatable suture wing at the bifurcation gives the physician the additional site to secure placement if needed. Temporary catheters are intended for short-term vascular access only and are not to be used for any purpose other than indicated in Bard Access Systems Instructions for Use pamphlet. The catheter must not be left in the femoral vein longer than 2 or 3 days. To maintain peak performance, it is recommended that subclavian and jugular catheters be replaced after 4 weeks. In this video presentation, Dr. Wong will demonstrate the Seldinger technique placement of the Niagara PC temporary dual lumen catheter via the right internal jugular vein, using the Bard Access Systems procedural insertion tray. It is important to select the appropriate catheter length. It is recommended that the 12.5 centimeter be placed into the right jugular vein of a smaller sized patient. The 15 centimeter length is appropriate for the right jugular, while the longer 20 centimeter length is recommended for left jugular applications. The selection of the correct catheter length will allow the tip to be properly positioned at the junction of the superior vena cava and the right atrium. Before attempting the insertion of Niagara catheters, ensure that you are familiar with the complications and emergency treatments listed in the Information for Use pamphlet.
Place the patient on an ECG monitor during the insertion procedure to monitor any cardiac arrhythmias that could be caused if the guide wire or catheter enter the right atrium. To perform this procedure, it is best to have the patient supine with the head turned away from the insertion area. The patient may be placed in Trendelenburg position to distend the jugular vein and lessen the risk of air embolism during insertion. The skin from the jawline down to the upper part of the chest and shoulder is cleansed with povidone iodine, and the area is draped, leaving the insertion site exposed. The catheter is prepared by filling the arterial lumen with saline and clamping. With the catheter ready to be advanced over the guide wire, the insertion site must be identified. The internal jugular vein emerges from the base of the skull through the jugular foramen and enters the carotid sheath with the internal carotid artery. It then courses posterolaterally to the artery and runs beneath the sternocleidomastoid muscle. In the upper portion, the vein lies medial to the anterior aspect of the sternocleidomastoid muscle. In the lower portion, the vein runs within the triangle formed by the two heads of the sternocleidomastoid muscle. There are three general approaches for internal jugular vein cannulation: the anterior, the central, and the posterior approaches. I favor the posterior approach as there is a lower risk of carotid artery puncture and a lower risk for trauma to deep structures in the neck due to the forward trajectory of the introducer needle. The entry point for the posterior approach is identified by locating the intersection of the external jugular vein and the posterior border of the sternocleidomastoid muscle, and then moving 1 centimeter superiorly. If the external jugular vein cannot be identified, this entry point roughly corresponds to the intersection of a perpendicular line dropped from the thyroid cartilage as it crosses the posterior aspect of the sternocleidomastoid muscle. Using a 25-gauge needle, local anesthetic is first infiltrated at the insertion site and a little bit more freezing deeper along the trajectory of the needle. Do you feel that?
No.
Okay. Just make a small nick in the skin. So I have a saline-filled syringe and my introducer needle. And again, I'm proceeding at a 45-degree angle to the sagittal plane and about 15 degrees forward angulation. Apply a little bit of vacuum on the syringe and advance slowly. And the vein's been found. I move the plunger back for several times to ensure that I'm located centrally within the lumen. I watch for back pressure to make sure it's not arterial, and I notice the color of the blood, which is dark, to confirm that it's venous. I watch the dripping. It's slowly dripping, again indicating venous blood. I advance the guide wire forward to approximately 20 centimeters. And I remove the needle, leaving the guide wire in place.
The trigger guide wire dispenser is designed with a thumb groove to provide the physician with a simplified, single-handed wire advancement. To use, simply pull back on the wire with your thumb until the tip of the guide wire dispenser is flush with the distal tip of the wire. The J, now straight, can be inserted into the needle hub and the guide wire passed through the needle to a distance equivalent to the catheter length. For convenience, the guide wire is calibrated in 10-centimeter increments. Do not pull back the guide wire over the needle bevel, as this could sever the end of the guide wire. The introducer needle must be removed first. Also, if unusual resistance is met during manipulation of the guide wire, discontinue the procedure and determine the cause of resistance before proceeding. Withdraw the catheter and guide wire if cause of resistance cannot be determined. Do not allow guide wire to inadvertently advance totally into the vessel.
The insertion site may be further widened by making a small surgical incision with a number 11 scalpel blade. The duolator dual diameter vessel dilator is now passed over the proximal end of the guide wire and introduced through the subcutaneous tissues with a slight rotating motion until it enters the jugular vein.
It is recommended to establish a clear tract with the Duolator dual diameter vessel dilator to facilitate the smooth insertion of the catheter. The Duolator dual diameter vessel dilator is 13 French and tapers to an 11 French tip, allowing for a one-step sequential dilation of the subcutaneous tract. Ideally, the 11 French portion of the dilator will be used to open the vessel, which lessens the trauma to deeper tissues. The 13 French portion will open the skin site and subcutaneous tissue. For clinicians that prefer a larger dilation, a second 12 to 14 French duolator is also contained in the tray. The BodySoft catheter shaft is made of softer polyurethane, which softens once warmed by internal body temperatures. The shaft design and softer polyurethane makes the catheter kink resistant. The soft, tapered stylet tip inside the venous lumen allows tracking over the guide wire. Once removed, the venous tip is blunt to allow high blood flow at low venous pressure.
Pass the catheter over the guide wire. Grasp the guide wire securely without advancing to prevent it from entering the right atrium. Continue to pass the catheter into the insertion site, being careful not to apply undue force to the shaft. The guide wire and stiffening stylet are now discarded. Confirm blood flow by attaching syringes to both arterial and venous extensions. With the clamps in the open position, blood should be easily aspirated through each lumen. I withdraw blood back from the venous port to show good flow through. I check the arterial lumen in the same fashion. And again, excellent flows.
The Niagara PC catheter is designed with a beveled arterial lumen to facilitate insertion. The blunt venous tip reduces pressure at a set blood flow rate. The round lumens allow blood flow rates up to 400 milliliters per minute at a venous pressure of less than 250 millimeters of mercury, as suggested by in vitro data.
Having correctly positioned the catheter, flush both lumens with a minimum of 10 cc's of normal saline. To maintain catheter patency, inject 5,000 units of heparin per ml into each lumen. Inject heparin quickly to ensure that it completely fills the lumens of the catheter. Maintain positive pressure while clamping extensions and attach sterile injection caps.
The number of cc's per lumen will vary according to the catheter length. For convenience, the priming volumes are printed on each extension leg to help ensure accurate heparinization of the catheter.
The final portion of the insertion is to secure the catheter. Attach the removable suture wing to secure the catheter at the exit site. The additional rotatable suture wing at the bifurcation may also be used if needed.
To facilitate easy insertion of the Niagara catheter, please follow these tips. Do not clamp venous lumen until venous insertion stylet and guide wire are removed. Clamping will kink stylet and prevent guide wire passage. Lock venous insertion stylet into catheter before insertion. The surgical incision at the skin exit site should be slightly larger than the wide, flat side of the catheter. Dilate 2 to 3 times with slow, gradual advancements. 13 French or 14 French dilation of the duolator device must enter the vein prior to catheter insertion. Insert the catheter flat side to the skin. Make sure that the venous lumen is cephalad, or closest to the head. This will help prevent arterial insufficiency of the catheter during dialysis. Do not twist the catheter during over-the-guide wire insertion. Pinch guide wire and Niagara catheter together. Advance together in 5 to 10 centimeter increments. Retract wire as needed. Catheter tip must be in lower superior vena cava for optimal performance. When replacing the pre-curved catheter in the internal jugular, use the removable suture wing to minimize movement at the exit site. The removable suture wing sits better on the catheter shaft if the physician sutures around the wing first, using the suture grooves prior to suturing through the holes. The removable suture wing at the exit site enables the physician to stabilize the catheter with either sutures, adhesive dressings, or both. The color-coded rotatable suture wing at the bifurcation is optional for additional security if needed and helps identify the catheter length.
In our renal unit, temporary dialysis catheters are dressed using two Tegaderm-type dressings applied in a sandwich fashion. The dressings are visually inspected by the hemodialysis nurses with each treatment. The catheter site is cleaned weekly with povidone iodine and a fresh dressing applied. Is that comfortable, Margaret?
Yeah, fine.
Okay. Terrific.
Affix the barred access system's heparin label on top of the dressing. This sticker alerts staff that a heparin lock is present, thereby preventing systemic heparinization. This barred access system's exclusive label is included in all packaging formats and is also available separately in rolls of 100.
Additional resistance may be encountered during the insertion as the arterial lumen of the catheter enters the skin and soft tissues. Adequate dilation of the entry tract with the vessel dilator and the additional catheter stiffness provided by the stylet facilitates the smooth insertion of the catheter. Overall, insertion of the Niagara catheter is a quick and simple process.
Dialysis must not be initiated until the X-ray has been taken and reviewed by a physician.
This is a single AP view of the chest post-line insertion. Seen here is the mediastinum and the lung fields, and the Niagara catheter itself. Shown here is the trachea, the right main stem bronchus, the left main stem bronchus, and the bifurcation point, or carina. Proper placement of the catheter tip should be within 2 to 3 centimeters of the carina, which corresponds to the intersection of the superior vena cava and the right atrium. Also, it's important to monitor for potential complications of line insertion, such as pneumothorax. There is no evidence of pneumothorax here.
The care and maintenance of the catheter requires skilled dialysis personnel following detailed policies and procedures. The catheter should not be used for any purposes other than the prescribed therapy. Maintain a sterile field whenever accessing the catheter extensions. Follow hospital dressing protocol. Alcohol or acetone-based solutions should not be used to clean the catheter or skin site, as the clamping extensions and luer lock connectors may be adversely affected. Povidone iodine is the recommended antiseptic solution to be used. Clean the exit site daily with hydrogen peroxide, followed by a povidone iodine solution. Clean from the catheter, working outward in a circular motion. It is important to place all clamps only in the center of the polyurethane extension pieces. Polyurethane could develop cuts or tears if subjected to excessive pulling or contact with rough edges. Repeated clamping near or on the hard plastic portion of the luer lock connectors may cause tubing fatigue and possible disconnection. Enzymes in blood and heparin may cause temporary sticking of extensions when clamped for extended periods of time. To release, open clamp and slide away, gently rotating the tube between the fingers and thumb until tubing separates. Warning: use of ointments with this catheter can cause failure of this device.
Approximately 5 cc of blood is withdrawn from each limb and discarded. A minimum of 10 cc's of normal saline is used to flush each limb of the catheter prior to the connection to the dialysis circuit. In the event of extreme negative arterial limb pressures or repeated alarms for arterial insufficiency, the lines may be reversed in an attempt to improve the blood flow.
Warning: to prevent systemic heparinization of the patient, the heparin solution must be aspirated out of both lumens immediately prior to using the catheter. Before dialysis begins, all connections to the extracorporeal circuit should be checked carefully. During all dialysis procedures, frequent visual inspection should be conducted to detect leaks and prevent blood loss or entry of air into the extracorporeal circuit. Excess blood leakage may lead to patient shock. In the rare event of a leak, the catheter should be clamped immediately. Necessary remedial action must be taken prior to resuming dialysis. Do not over-tighten connectors, as the wear and tear over repeated use could degrade the connection integrity.
With each hemodialysis, the patient's temperature is checked at the start and end of treatment. The catheter exit site is visually inspected for purulent drainage or erythema of the surrounding skin. Fever or evidence of an exit site infection is reported to the physician. If clots are noted on the initial withdrawal of blood from the catheter, the internal volumes of each limb are verified to ensure that an adequate volume of heparin solution is being used to flush the catheter at the end of each treatment session. If clots are found on repeated occasions, a higher concentration of heparin solutions is used. We get very good blood flows, anywhere ranging from 400 to 450 mLs per minute. It gives us better clearances of urea and creatinines. Patients eventually may be on for shorter periods of time, so physicians, according to their KTUs, may decrease their times over a period.
Bard Access Systems Niagara catheters are packaged in 3 formats: catheters alone, kits, and complete insertion trays.
Our experience with the Niagara catheter has shown that it is easy to insert and consistently provides high blood flow rates. This allows for more efficient dialysis and the achievement of clearance goals.
Bard Access Systems and Vascath Incorporated. Designs for life.